much of what we covered today, you guys have seen. Okay, so we're gonna go pretty briskly through a lot of this. I'll point out some important structures. What we really care about, though, less so is the structures, and much more so is how does all this work? How does the cardiovascular system work? How does it change during exercise? And then realistically, when it doesn't work right, what happens, right? Why is that? So we'll get through some structures, we'll get through some functions. I know the principles of health and fitness and chronic disease. You guys have had those classes. You guys have talked about sort of pathological things, but understanding how the cardiovascular system works is really important, because about a quarter of all deaths in America and in industrialized nations are due to some sort of dysfunction in this system. Okay, and so understanding what it's supposed to do is helpful. And then understanding, when we get into training responses, how this system responds really well to training and how that protects us from cardiovascular disease is also going to be really important. So we'll hit those. We'll talk about circulation. We'll talk about control mechanisms, about how do we get heart rate up? How do we get stroke volume up? How do we get and change where blood goes? And then how do we enhance oxygen transport as we sort of move along? Okay. So the cardiovascular system, and again, I can go on, and Dr. Paddock probably get angry with me for saying this, it's a support system. Okay, it's a support system, but it supports, in some ways, like metabolism, all the other structures, all the other physiology and function in your body. Okay, it supports metabolism, therefore it supports muscle. It supports the pulmonary system. The hormones have to go into the blood to circulate, so it supports the endocrine system. It supports the brain. It is 100% necessary and key for sort of all the other functions that we're going to have. Okay, so virtually all bodily functions depend in some way on proper function. It plays a huge role in exercise and performance. Okay, poor cardiovascular function, poor cardiovascular health is one of the key things in preventing people from exercising more. All right, so we'll get into a lot of that. We see lots and lots of adaptations because of that. We'll go through some kind of key functions. We'll talk a lot about delivery. So how do we get oxygen in and circulate it out to our muscles, okay, or to whatever, to the brain, to other tissues that need it. We'll talk a little bit about removing carbon dioxide. We've already talked to some extent about transporting hormones. We will get into maintenance of body temperature at the very end of class, okay? We will spend no time talking about the immune functions in many ways of the cardiovascular system, but it also plays a really key role there, okay? From a structure standpoint, we're going to kind of break it down into three big primary groups. We'll talk about the heart, we'll talk about blood vessels, and then we'll talk about my favorite part of all this, we'll talk about the blood itself, okay? So how does the heart work? What does it look like? What's proper function there? What are blood vessels? What are the different flavors of blood vessels? How do they work? How do they help us get blood to certain places? How does that control work? Okay, and then we'll get into the blood itself, because there's some really cool properties of blood, some really interesting things that change in your blood as you become acclimatized to the heat, as you exercise more, right? How we change hemoglobin concentrations, how we change plasma volume, and the effects that has on exercise and performance. Okay, all right. Now, show of hands, who had anatomy here? Most of you. Okay. Now, we're not going to tell Cindy this. We're not going to tell Cindy. Okay. All you have to know, all that is important, I shouldn't say that. All I want you to know are the four chambers of the heart. Okay. The four chambers, superior vena cava, and the aorta. That's all I want you to know structural. Okay. We're not going to get into how many flaps the valves have. We're not going to get into how thick the walls are, any of that kind of stuff. All I want you to know is right atria, right ventricle, left atria, left ventricle, okay? Blood comes in from venous circulation through the superior vena cava onto the right side of the heart. Then it goes to the lungs. Then it comes back with more oxygen, left atria, left ventricle, out the aorta. All I want you to know. You guys think you can do that? Yeah? You think you got that part? Okay, that's good. The other things are important. They matter, right, if you're a cardiologist or something else. But for what we need, if we know that much, we'll be in good shape. Okay? We'll be in good shape. Remember, you're looking at the heart as it sits, right? You guys make a fist, point the sort of where the crook of your pinky down towards your left hip, put it right here. That's about how big your heart is. That's its orientation. So when we look, the right side is actually the left side, and the left side is actually the right side. So that's how we're going to go. Okay? All right. In some ways, much more important for what we're going to discuss in class is going to be some special properties of cardiac muscle fibers or cardiac muscle cells. Okay? The heart is a muscle. It looks under a microscope a whole lot like skeletal muscle. It has striations, right? It has sarcomeres, it has myofibrils. It looks like skeletal muscle. It contracts, right, with actin and myosin, just like skeletal muscle. Okay? So it's muscle, much like skeletal muscle that we've already talked about before. Okay? But it's a little bit different. It's a little bit different in some key ways that are going to help it perform its function. Okay? That make it different than skeletal muscle. It has a very, very extensive capillary network, way more capillaries coming off of the coronary arteries and coronary arterioles in cardiac muscle than in skeletal muscle. That means we have significantly more blood flow that goes to the heart per sort of area of muscle fiber than we do in skeletal. Okay? When we impair some of that blood flow, that things happen. Okay? The other interesting thing about cardiac muscle, it has a lot of blood flow, and then we need that blood flow to bring oxygen, but we have a huge amount of mitochondria. Cardiac muscle its cytoplasmic volume is about half, or a little under half mitochondria. It's basically actin and myosin and sarcoplasmic reticulum and mitochondria, and that's it. That's all that's in there. Okay? Skeletal muscle in super well-trained people might get to about 50%, 10% cytoplasmic volume of mitochondria. So there's lots of blood and there's a shit ton of mitochondria. That means cardiac muscle is really, really good at using aerobic metabolism. Okay? It's really good at using aerobic metabolism. That's why, okay, my heart has been beating for, I don't know, 47.5 years or thereabouts. Okay? Constantly. Long time. Can you imagine? It's like every second you're just like curl. You've been doing this your entire life, just all the time. Imagine how tired your bicep would be. You just did this all the time. That's what your heart's going to do. Okay? That's what it's been doing. It always works for the most part, and that's because it doesn't make lactic acid. Okay? It has lots of oxygen. And it has lots of mitochondria, so it can make a huge amount of ATP in the aerobic system. Okay? And that is really, really key and important to proper cardiovascular system function. We need the heart to be able to contract over and over and over and over again for years, years, years. Okay? So that's again how form or anatomy, structure, and parts function. We have some other things, though, some other specialized structures in cardiac muscle that make a difference in skeletal muscle. And again, a lot of it's related to how it functions, specifically how we tell cardiac muscle to contract. Okay. Cardiac muscle is different than skeletal muscle. There's no cognition to contraction. At least there's no cognition part in contracting cardiac muscle, right? None of you think about making your heart beat every time, do you? You don't think about it, it just happens, okay? So there's no cognitive part that's going to be in there. And so because of that, we use a little bit of a different way to make it contract, and we need these other special structures to help us do that, okay? We have some things that help us hold cardiac muscle cells, cardiac muscle fibers together. We have what are called desmosomes, okay? They're clamps, basically. They span at the edge where one fiber meets the next. They hold on really, really tight, okay? Keep them together. We don't want them to get separated because that's going to impair our ability to transmit action potentials. We also have what are called gap junctions. Gap junctions are windows or doorways. They're just pores between one fiber and the next. And they allow the passage of ions to move really, really quickly. And so it helps us move an action potential even faster from one cardiac muscle fiber to another. Okay? So desmosomes and gap junctions occur at that junction between fibers that we call an intercalated disc. Okay? It's just sort of a broad name for the area where those fibers are going to be connected to each other. All right. I have some pictures here if you really care about seeing them. There's an H&E stained picture on the top left from a light microscope of cardiac muscle, okay, or cardiac muscle fibers. They look a lot like skeletal muscle, okay? You can see the nucleus, you can see the striations and things that are going to be there, but it's this cartoon that shows where they're going to come next to each other, how it has that big surface area, that kind of zigzag line, that's the intercalated disc, okay, right? And then at those areas, there's going to be the gap junctions, and then there's going to be the desmosomes that are going to help hold us tightly together, all right? And so that's all going to be related in many ways to how does the heart contract? How do we help ensure proper transmission of action potential so the heart contracts the way we want it to? Okay. Cardiac muscle, as I said, there's no cognition, no thinking about making your heart go faster. Okay, so we make cardiac muscle contract using something called the cardiac conduction system. Okay, a piece or a place in the heart begins the contraction. It spontaneously generates an action potential. This is called the sinoatrial node or the SA node. I know you guys have already learned about it, but at the SA node, there's a collection of sort of nerve fibers right at the top, okay, of the right atria. And in that atria, in that node, there are leaky calcium channels. And what that means is there's always a little bit of a drip, 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 drip of letting calcium in. As the calcium comes in, we will eventually move towards polarization. We get it polarized, we get an action potential, and then we transmit that action potential. We conduct it, okay, from the SA node across the nerve fibers and across the sarcolemma of the cardiac muscle to other parts of the heart. Okay. And so that spontaneous generation of action potentials by the SA node is called autoconduction. Okay, autoconduction. So this happens whether you want it to or not. Now there are some things that we can do to potentially alter how often it does that. We'll talk about that in a minute. The SA node in most of you has an intrinsic firing rate, so it will spontaneously be polarized. in the neighborhood between 70 and 75 times per minute, okay? A little bit more often than one action potential per second. And it polarizes, it repolarizes. It depolarizes, it repolarizes. Okay? So there's an ability for us to kind of look around and do all of that. Okay. Here's some anatomy I do want you to do. Okay? This slide outlines very clearly how the cardiac conduction system works. Okay? There are 4 components: the SA node, the AV node, the something called either the AV bundle or the bundle of His, even though it's spelled His. Okay, and then some special nerve fibers called Purkinje fibers. Right. So if you look on the right, you look at this at the very top in the right atria there, you see the SA node, number 1. Okay, the SA node is the autoconduction place. It has the calcium channels and it generates an action potential. It then moves across the atria until it reaches the AV, or the atrioventricular node. Okay. Then from there, it is connected to the AV bundle and the Purkinje fibers. So you're going to get this spreading out of the action potential across the right atria. Okay. It then makes it to the AV node and it goes down the middle of the heart. So we use nerve fibers here because the nerve fibers conduct the action potential faster than it can move if it just moves across the surface of the cardiac muscle. And so what this creates then is it starts at the top. The atria contract and forces blood into the ventricle. Then the action potential shoots down the middle, right? It gets to the bottom of the heart, and then it moves itself back up. And so what it does is you force the blood into the ventricles, then you start the ventricular contraction from the bottom, and you squeeze back up, like you're squeezing toothpaste out of a tube. Okay? And so it squeezes back up, which is good because the pulmonary arteries and the aorta are on the top, right? They're above, right? They need to move the blood up in order to get it through the pulmonary arteries to the lungs or out of the aorta. The aorta is at the top, so we're working against gravity, so it needs to go from the bottom up. Okay? That's how this works. Okay? All of you guys right now have this SA-AV down into the Purkinje contract back up. You have this normal rhythmicity that we're going to see. Okay? We can measure these electrical signals. Okay? We put electrodes around your heart. Any of you guys who had exercise session prescription have seen an EKG, hopefully by this point in the semester. We put the EKG electrodes on, and we monitor basically depolarization from the SA node and the atria through the AV node down into the ventricles. Okay? When this gets messed up, which it often does in people that have had a heart attack or people that have some kind of cardiovascular disease, we can measure it and we can use the EKG to figure out where in the midst of all of this, what precise location is the problem occurring. Okay? That's what an EKG can tell us. If you have an impairment in coronary arteries, you block them up, you can't get blood with oxygen in it to certain parts of the heart, that affects this conduction, and it shows up on the EKG. And that's how we know, okay, you have less blood flow going to the middle portion of the right ventricle, but the left ventricle is okay. Right? We can see those differences on the EKG, and it all comes back to this. Okay? It all comes back to this. When you're watching, I don't know, any medical show, Grey's Anatomy, right, which is still been on right now, it's still on TV or Netflix or something, right, like 20 years later. Okay? We're gonna get American voiceover at the end over a sad song or something. They still do that. We haven't watched it in forever. We used to watch it a bunch. But when you get the panels out, somebody's having a heart attack, right? And you shock them. What you are doing is trying to reset the rhythmicity here. You're trying to get everything to depolarize at once. and reset so the SA node goes first, and then things move down. Because sometimes when you go into cardiac arrest, what happens is things get out of order. The ventricles are contracting at the same time as the atria, right? The conduction system gets impaired, everything is fluttering around, and then the blood can't go in. So you shock them, and it puts that back to normal. Okay? It tries to put all of that back to normal so that we can repolarize and depolarize in the correct sort of sequence. Okay. Now, as this happens, as you get action potential, okay, each chamber of the heart will contract, then it will relax. Okay? And there's an order to all of it. The period of contraction we call systole. Okay? Systole. The period of relaxation is called diastole. Okay? Every chamber of the heart in one heartbeat has a period where it contracts and it relaxes. So in each cardiac cycle, which is one heartbeat, all four chambers contract and relax. Okay? But they do it in sort of an offset. The atria contract while the ventricles are relaxed. Blood moves via pressure. So you squeeze the atria, the ventricles are relaxed, you squeeze the blood out of the atria down into the ventricles, then the atria relax, then the ventricles contract. The ventricles contract and it shoots the blood into the lungs or in circulation, and while that's happening then, as that blood leaves, it pushes more blood back in. When the atria are relaxed, then they can come into there. Okay? So during systole, we contract and we squirt the blood out. During diastole, it's relaxed and blood comes in and fills in those chambers. Okay? The period of time, right, that it takes for each chamber to contract and relax changes a little bit as your heart rate changes. Okay? At rest, most of you guys are resting maybe a little more than I would like right now, but at rest, about 2/3 of the time in a heartbeat, each chamber is in diastole. So there's more time for it to be relaxed. There's more time to fill that chamber up with blood. That's good. Okay? As you guys will see on Wednesday, the amount of blood we can get into a chamber has very dramatic effects on how hard or how forceful that chamber can contract and what our cardiac output. So more filling time is usually better. But as heart rate increases, time that it takes to contract stays relatively constant, but the time between heartbeats shrinks. And so we lose some diastole, we lose some filling time. And in some instances, in some people, during very, very high intensity exercise, when your heart rate is very, very near its max, especially folks that are y'all's age, as it nears 200, then we may run out of diastole time. We can't fill each chamber as much as we would like. That may limit cardiac output during maximal exercise. It's in untrained people, it happens near max a lot. In trained people, a little bit less. So that's what's going on here. Okay? That's what's going on here. Okay. Here's an EKG. We talked about that a few minutes ago. I'm sure you guys have seen these before. I'm not going to ask you to draw one, but I do want you to know sort of what each of these waves means, because each wave corresponds to a particular electrical event or a particular piece of the cardiac conduction system and its proper function. Okay, so if you will look here on the left, okay, this area in kind of the pink color, that little uptick there is called a P wave. Why is it called a P wave? I don't know. I should have looked all of that up, but the P wave denotes atrial depolarization. So this is contracting the atria. This is the SA node, generates an action potential, the atria contracting. That's what the P wave denotes. That's the start of a cycle. We then get this area in light blue, this QRS complex, okay? That denotes that the action potential has moved from the atria through the AV node down the bundle of discs to the Purkinje fibers, and the ventricles depolarize. So atrial contraction, ventricular contraction, okay? Then we get this sort of area in the green afterwards, so it's called a T wave. The T wave is repolarized, okay? It's the ventricle going back to resting membrane. If you can't get a T wave, then the ventricle can't repolarize and it can't contract again. Okay? That's what's going on here. P wave, QRS, T wave. I will mention it. I'm not going to ask you about it, but it's really, really important if you care about interpreting an EKG and if somebody has some type of arrhythmia or ischemia, lack of blood flow to a particular area of the heart. This area between the bottom of the S here, the S wave, the very end of the QRS complex, and the T wave is called the S to T segment. And changes in how this particular piece looks is diagnostically significant for identifying lack of blood flow to certain areas in the ventricles. Okay. So ventricular ischemia or a lack of blood flow to certain areas causes, see how it ticks up and then is a little bit flat and then you get a T wave? Ischemia causes all of this to sort of shift down at an angle. It shifts down and you don't come back up and get a little flat spot before the T wave. It's down and then it angles right back up into the T wave. That's called S and T segment depression. And it's one of the hallmark diagnostic criteria for ventricular ischemia. So if somebody is having or has had a heart attack, or we do these crazy things, they think you had a heart attack, and you go to the hospital, and the first thing that they do is throw you on a treadmill and try to give you another heart attack. Because we need to see when the heart has to work really, really hard, are we lacking blood flow in certain areas? That's when it manifests itself. These symptoms manifest much more so when you make the heart work hard. So you've had a heart attack, you show up at the hospital, throw your ass on the treadmill, and they say, go. Or sometimes they don't put you on the treadmill, and they give you a drug that makes your heart rate go up, 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 up. It's basically a drug that mimics the cardiovascular response to exercise. Which is a crazy thing if you guys haven't ever seen that. You're just sitting there and it's just boom, 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 boom. The heart's working really, really hard. I went back to my mom, she said it's this weird, crazy, like very, very disconcerting sort of feeling. Okay? But that's an EKG. That's all I want you guys to know. We're not going to go through arrhythmias. We're not going to go through the different pathologies that show up and look in certain ways. We'll do a little bit of that exercise testing prescription. I just want you to be on the surface aware of what is going on. Okay? Of what is going on. P wave, QRS, T. Okay. Okay. We've been talking about heart rate. Every time the SA node depolarizes, you get a contraction and then a relaxation in each of the chambers. That is one cardiac cycle or one heartbeat. Okay, that's heart rate. The other really important aspect and kind of variable in the cardiovascular system that is really important for exercise. I can make an argument that in all of you guys in the room who are roughly the same age, that this variable, stroke volume, is the single best predictor of who will have the highest VO2 max in the classroom. Okay, whichever of you has the largest stroke volume wins. Okay, and we will get into how you get a big stroke volume. Okay, at some point. Okay. Ladies, can I borrow y'all's waters? Okay. I'm not going to drink them or anything. I'm just going to touch them. Okay. Stroke volume is the amount of blood that leaves the left ventricle every time your heart beats. Okay. We calculate stroke volume by subtracting two numbers from each other. The first number is something called end diastolic volume, and then the second number is called end systolic volume. So think of it this way, okay? This water bottle is your left ventricle, okay? It's your left ventricle. In this one, this is the left atrium. It has a whole bunch of blood in it, okay? When we are in ventricular diastole, we contract the atria, and I would pour water and fill this bottle up, okay? The ventricle fills up with water, okay? It's relaxed. Atria contracting. So we have at some point then, atria stops contracting, the ventricle is about to begin contracting. So the amount of blood in the ventricle, or the water in this bottle, right before it begins to contract is called end diastolic volume. So we fill it up, okay? This bottle is only so big. Your left ventricle is only so big. There's a finite amount of space and therefore a finite volume of blood that can go in. The longer it's relaxed before it contracts, the closer we can get to filling it to its capacity. Okay? So pour, fill, stop atrial contraction. Now we're about to have ventricular contraction, and I'm not going to do this, but I would squeeze the bottle. Okay? As I squeeze the bottle, it forces the water out. Okay? Then it squeezes, then it relaxes. And when it relaxes, it's going to look like this. I squeezed out some of the water or some of the blood, but not all. There's some left in here. Okay? The ventricle contracts, not all the blood leaves. What's left in here is end systolic volume. So if we know how much was in here to start with, and we know how much is left after the contraction, the difference in those two numbers is how much was ejected. Does that math make sense to you guys? Fill it up, contract, there's some left. So whatever, we knew where it was when it started, we know how much is left. The difference is however much we poured out. Okay. That's stroke volume. Thank you. Okay. We don't use it very much in exercise physiology. But if you ever go to a cardiologist, okay, which most of you will at some point in your life, you all probably have grandparents that are going to cardiologists now. Okay? You go to the cardiologist, they do something called an echocardiogram. They put an ultrasound on your heart, right? Sometimes they'll infuse you with dye that will show up on the, they put an ultrasound on, and they measure how big is your left ventricle. They measure blood flow coming in and going out. And they can calculate something called ejection fraction. It's not that important for us in exercise because most people that exercise, they're doing fine. But ejection fraction is, okay, stroke volume as a percentage of end diastolic volume. So basically, how much blood out of the total that was in at the end of diastole. Fill the heart, the left ventricle up as much as you can, then it contracts. So it's basically what percentage is leaving. That's the ejection fraction every time the heart beats. And in most of you guys who have normal cardiovascular function, ejection fraction is about 2/3. You're ejecting about 2/3 of the blood in the left ventricle every time your heart beats. When we begin to exercise, again, if you have normal cardiovascular function, ejection fraction increases. Okay? The amount that it increases and what that number is at rest tells us some things about the health of the ventricles. Tells us some things about how strong that cardiac muscle is. People that have cardiovascular disease, especially people that may have congestive heart failure, where the muscle gets weaker, they're not at 50% at rest, or at 60, they're not at 2/3 at rest. I can't talk today. Maybe they're at 50% or 40% or something compressed. So the heart is not strong enough to eject as much blood as it normally would. During exercise, if that number doesn't go up enough, then your stroke volume can't continue to go up and your cardiac output can. So that's the utility. We don't use this much in exercise, but it's a thing that lots of cardiologists will try to measure and use it as an index of cardiovascular system health. Okay. Okay. Before we put all of the kind of stroke volume and heart rate stuff together and those things, we can talk about how blood moves. Okay, how your blood circulates. Why having a contraction causes it to move, and why having relaxation in a particular ventricle or atria causes things to fill up. And to understand how that happens, we have to understand the idea of pressure and blood pressure. Okay, blood is a fluid. Fluids move via differences in pressure from one place to the next. When you go and turn on the faucet on your sink, what you are doing is moving water from an area of high pressure in the pipes to an area of lower pressure right into your sink where there's basically no pressure. Fluid and air, fluid especially, moves via differences in pressure. And so we need to understand how much pressure the blood is exerting in different locations in the body if we want to understand why blood moves from one place to the next, to the next, to the next. Okay. So we measure pressure, okay? When we measure blood pressure, what we are actually measuring is how much force, basically, is the blood exerting on the walls of a blood vessel. So when you guys measure, right, blood pressure in the arm here, okay? My mind's not working this morning. What the hell is this artery called? Hi, help.
I'm so sorry, what did you say?
What is this artery?
Artery?
In the arm.
Brachial?
Brachial. My mind is not working. We want that in. When we measure brachial blood pressure, okay, what we are measuring is essentially how much force is the blood in the brachial artery pushing out on the walls of that artery. And we know that by putting external pressure on, and how much pressure do we need to close it off? Okay, to close it off. So we can measure blood pressure in any vessel in your body. Okay, blood pressure tends to be highest in the left ventricle. It's then a little, not quite as high, but also very high in the aorta, and then the pressure falls as we move away from the heart and the arterial tree. In the capillaries, it's lower still, and then in the veins, it's even lower. Okay, so blood moves from high pressure to low pressure. It's trying to get away from that high pressure being generated in the left ventricle and in the aorta, and that is what sort of forces or pulls the blood along across all of your blood vessels. We express blood pressure as two numbers. One is called systolic pressure. Systolic pressure is the highest amount of pressure exerted on a vessel wall while the left ventricle is contracted. It contracts, forces the blood to move, that raises the pressure in that vessel as high as it's going to go. Okay. Then we have the second number that is usually lower. If it's not, go to the hospital. Okay, called diastolic pressure. Diastolic pressure is the pressure being exerted while the left ventricle is relaxed, while it's filling up. Okay, so you get this alternating cycle of systole, diastole. So pressure goes up, then it comes down, goes up, then it comes down. Okay, that is blood pressure. Each of these numbers matter. Okay, each of these numbers matter. Systolic pressure tells us about the driving pressure that is going to allow the blood to move. Okay, if it's too high, that can be bad. If it's too low, blood won't move. Diastolic pressure tells us something about the resting state of your blood vessels. If diastolic pressure is high, that's bad. Okay, High diastolic pressure means the heart has to work harder to overcome that diastolic pressure to ever get the blood to move, and over time, that can cause problems. If you have high diastolic pressure, then that can indicate to us that you have poor arterial health, you may have blockages, or you may have poor kidney function, or any number of other things. But that can be bad. Again, a thing we don't use very much in exercise physiology, but I want to make you aware of it, is again, you go to a cardiologist, they'll try to show this number to you. It's a thing called mean arterial pressure, or MAP, okay? Mean arterial pressure is a way for us to try to average out over a cardiac cycle the amount of pressure being exerted on a blood vessel or on those vessel walls. So mean arterial pressure, we usually do it at rest, and we take your systolic pressure, multiply that by 1/3, we then take your diastolic pressure, multiply that by 2/3, and that gets us the mean arterial pressure. So over an average cardiac cycle, this is how much pressure is being exerted. Again, if this number is high, okay, it is much more sensitive to elevated resting diastolic pressures than systolic. Okay, it's going to try to tell us something about what's happening with your blood pressure. We don't use it very often now, but it used to be much more widely used when looking at prescribing medications for blood pressure and the like. Okay. Okay. Here's a graph showing from the left ventricle through the arteries, the arterioles, the capillaries, veins, and then back to the right atria, the change in pressure over a cardiac cycle. Okay. And what you will note is that during systole, left ventricular pressure is very high. During diastole, left ventricular pressure is super duper low. As we move out though into the arteries and the arterioles, there's still this cyclic change, but because there is some blood left in there all the time, much more blood left in your arteries than in the ventricle, the diastolic pressure is much higher in arteries than it is in the left ventricle. As you move down the tree, pressure falls, allowing blood to move. Okay, allowing the blood to move. All right. We'll do the last little bit here, then I'll turn you guys loose. So, a really important measure, really important variable for us to understand the ability or the capacity of the cardiovascular system to circulate blood, get that blood out to your tissues, is a variable called cardiac output. Cardiac output is the product. So you take your heart rate, so how many times is the heart beating, and you multiply that by stroke volume, just the amount of blood that leaves every time the heart beats. Okay? So number of beats per minute, amount of blood that is ejected every time it beats, multiply them together, and we get a volume of blood that circulates through the heart or out of the aorta, however you want to describe it, every minute. Blood pumped per minute. That's stroke volume. And heart rate, I'm sorry, my brain is still not working. That's cardiac output, which we abbreviate as Q. Why is it Q? I assume because they were worried that CO would denote, right, carbon monoxide, or something to that effect. Cardiac output at rest in a sort of average size college age person is going to be between 4, maybe 5 and 6 liters of blood per minute. Okay. Most of you guys have between 4 and 6 liters of blood in your body, somewhat based on body size. So a general rule of thumb is that you circulate all of the blood in your body through the heart 1 time every minute when you are at rest. When you are at rest. During exercise, in untrained people, cardiac output tends to go up maybe 4 or 5 times. You can go from maybe 5 liters per minute at rest to 20 to 25 liters per minute during exercise. In people that are very, very highly trained, their resting cardiac output might be 7 or sometimes even 7.5 liters per minute. It can get up into the mid-30s. So those people during exercise can raise it about 4 or 5 times. That's primarily related to a kind of small but meaningful increase in stroke volume as exercise begins. And then a fairly significant, most people, maybe a doubling or maybe 1.25 times increase in heart rate as exercise goes along. Okay? Whichever one of you in here has the largest cardiac output per your body size at high-end exercise will have the highest VO2 max. Cardiac output is strongly related to max VO2. Because it's the ability of you to move that blood with oxygen out, okay, through the heart, through the lungs, to the tissue. So this is a really, really important predictor of exercise performance. Okay? A really strong predictor of exercise performance. If I do something to you to limit the ability to increase heart rate and the ability to increase stroke volume, it limits cardiac output. Because we've decided, probably from the back, that we do not like to prescribe people Xanax anymore. Then people like me, when I have a particularly anxious type of day, I used to take a Xanax. My doctor won't prescribe me Xanax anymore. It's good, it's very addictive, it's not great. What I take now is something called propranolol, which is a beta blocker. And what it does is it prevents the SA node and the ventricles from responding to epinephrine and norepinephrine. So I can't increase my heart rate or my ventricular contractility during exercise if I've taken a propranolol to the same extent that I could. Right? And we'll talk a little bit more about that. Okay. Now, have a good day. If you've got a test, give it back to us. If we don't get it today, you're getting a 0. I'm coming after you.
All right, let me drop the ball to the break.